Okay, so chapter 22 on the respiratory system. So the major function of our respiratory system is to supply the body with oxygen and get rid of carbon dioxide. Your body needs oxygen to be supplied to all of your cells, all of your organs in the body. Carbon dioxide is considered a waste product, and we give that off when we exhale. The four processes collectively for respiration to occur. You have pulmonary ventilation, which is normal breathing, movement of air in and out of the lungs. So that's just normal breathing, no kind of extra attitude or force put behind it or exaggeration. You also have external respiration, which is oxygen and carbon dioxide that is exchanged between the lungs and the blood. So that is your lungs giving off the oxygen that's going to your tissues, and then carbon dioxide being pushed into the lungs, and then you're giving that off as waste. And that was a part of the earlier chapter 17, going through the flow of blood through the heart, or chapter 18, and going through the flow of blood through the heart. So this is when it goes from the pulmonary trunk to the pulmonary arteries, and you go into the lungs and get that exchange process there. Then you have transport, which is the oxygen and carbon dioxide being carried in the blood after you pick up that oxygen in the lungs. And then from there, you into internal respiration. Is the oxygen and carbon dioxide exchange that takes place in your tissues. And that's when you're going back into the heart through the pulmonary veins to the left atrium, left ventricle to the aorta, and then from the aorta to your arteries, arterioles, and so forth. So that's the exchange there. So these are the four processes that must take place for the entire respiratory system to be able to function. So the zones that you have the conducting zone, which consists of the nose and the paranasal sinuses. And the function is to simply for an area for air to move through. So you have at this point no exchange of oxygen and carbon dioxide. So the zones, your nose and paranasal sinuses, they're simply acting as a conduit or a passageway for the air to simply move. The structures that you can see on the outside, your root, dorsum, nasa, the apex, the philtrum, and the vomer. You have your external nares or the nostrils. Also, you have the nasal, frontal, maxillary, and vomer bone, which were all a part of A&P1, lateral, septal, and alar cartilages that are also a part of it. So all of these structures you can see on this picture here. And this picture is simply a picture from the book, and you can locate all of the areas that I just clicked in. And these are just the external structures, like I said, that you see on the outside that are part of that respiratory system. And I'm sorry, here's the apex of the nose. Nares, which are the nostrils, another name for the nostrils. Here are other structures, the bones. You can see frontal bone, forehead, nasal bone, the two bones making it up. The end of the nose will be the cartilages. Then you have the maxillary, which is the upper facial bone. And all of those are the areas that are part of they're considered external because they're the external skeletal framework, but they are underneath, of course, the skin. Nasal sinus consists of the ethmoid and sphenoid bone, which you can see the ethmoid, the roof of the mouth, making it up, but you can also see it in the skull, and you may remember those from A&P1. You have your palatine bones that make up the roof of the mouth and the palatine process. The vestibule consists of the vibrissae, which are the nose area, the hairs in the nose, and those help with movement and cleansing of the air. Olfactory mucosa, which are your smell receptors. The type of cells making it up are the pseudostratified ciliated columnar. They consist of the goblet cells, and the job of the goblet cells is to produce mucus, because the nasal cavity is lined with the mucous membrane. So that helps too with the mucus secreting or making mucus. You also have the pseudostratified ciliated is for secretion and propulsion. So that's all a part of the functioning. The nasal concha with the inferior meatus. And then you also have the sensory receptors located there that help to, or with the sneeze reflex. Your concha and the air that's going in at all of this time in that sinus is being cleansed and filtered and moistened while it's going into the nasal area or the nose when you're pulling it in, breathing in that air. So you can locate all of those in here in the picture. You see the nasal concha and then the folds underneath. So you can imagine that air that's being pulled into the nose is going in kind of like a whirlwind. And you see how my mouse is moving around because that's how it's going in. And that air is being cleansed as it's moving in. It's also, remember, it's lined with that mucous membrane. So that helps to cleanse that air, filter the air. And as it moves, before it moves further along the respiratory tract. You also can notice the olfactory nerves here. Those are your smell receptors, and you see olfactory here. And those are your receptors that help with smell. And then you can also see the concha, again, the middle, the inferior, and the superior nasal concha in the nose as well. Paranasal sinus is paired of the frontal, the sphenoid, ethmoid, maxillary bones. Those are facial bones. And they function to lighten the skull. They help to warm and moisten the air. And they, of course, help with resonance, which, of course, is the quality of sound that we give with speech. So you can notice there in this picture, I believe, I'm not mistaken, it wasn't one in the book, but I pulled it offline. I just Googled to be able to show you those bones with those air-filled cavities, the sinuses inside of the bones within that facial region. Moving from the nose, air goes from there to the pharynx, and you'll notice your notes are in order from the flow of air through the respiratory tract. So you have the pharynx, also known as the throat. That's the next area where air is moving. From there, 3 parts of the pharynx: the nasopharynx, the oropharynx, and the laryngopharynx. Nasopharynx is the air passageway only. You have the soft palate and the uvula that helps to block off during swallowing, and it's an automatic response. When you swallow, your uvula will raise up to block off the nose. And I think I'm getting ahead some more into the digestive things, but all of this is an automatic response to keep things in the proper track. The pharyngotympanic is part of the auditory tubes. The adenoids are the pharyngeal tonsils, also known as adenoids, and they are sometimes removed when you remove your tonsils. Those and you have this oropharynx. It's ciliated, pseudostratified, and it becomes stratified later, squamous, to be able to protection of that air that's moving down. And then you have the palatine and lingual tonsils. The laryngopharynx is a passage for food and air, and it moves to the larynx, also known as the voice box, but that's the next area that we're going to talk about. So those are the 3 parts of the pharynx: the nasopharynx, oropharynx, and the laryngopharynx. So here are those areas. You can see the nasal cavity that we just discussed, and then you can see the pharynx, and then you see the larynx here. But the pharynx, when you zoom in, here are the 3 parts of it. They're very short: nasal, oro, and laryngopharynx. Next, you have the larynx, which is also called the voice box. It attaches to the hyoid bone. The hyoid bone was the one bone that didn't attach to any other bone or articulate with any other bone in the body. The larynx continues with the trachea, and you'll know the trachea because of the rings that are on it. And then it functions to provide an open airway. It routes air and food into their proper channels. Food goes towards the esophagus, air would go towards the trachea. And it's also functioning in voice production. The larynx is made up of cartilage. You have 9 different cartilages that make it up. You have the thyroid, which is the largest, and it's the laryngeal prominence that's known as the Adam's apple, that's larger or more prominent in men. The cricoid is the first ring after that thyroid, and then you have the arachnoid, the cuneiform, and the corniculate cartilages. Then you have the epiglottis that's made up of elastic cartilage, and it covers the laryngeal inlet during swallowing to guide things to stay in the respiratory tract versus if you wanted to go in the digestive tract. And I mentioned that the epiglottis is elastic cartilage because the other cartilages, thyroid, cricoid, arachnoid, cuneiform, or corniculate, those are hyaline cartilages. You can see those here in the picture. There's the epiglottis. And you can see the next one here is the thyroid cartilage. It's the big one. Right below it is the cricoid cartilage. You can see the laryngeal prominence there in the front that makes up the Adam's apple. Here's the hyoid bone sitting right on top of that larynx. And then here's the others that you couldn't see there. The cornicular cartilage, and remember it's in a pair. And then the arachnoid cartilage, and it's a pair. So it's only pointing to one side, but the other side is included. And then below that, you can see how you can see the cricoid cartilage again, and the thyroid cartilage, the big one, you can see it as well. You can also see this epiglottis from this back view. And this is the back view of it. The previous picture was the front view. Here's the side view. And you can see cuneiform. You can see corniculate and arachnoid with this one also. So for voice production, allowing for speech, you have your false vocal cords, which would be your vestibular vocal cords, and they help with closing the epiglottis. You also have your true vocal cords. They're white due to the lack of blood vessels, and they actually vibrate as air come up from the lungs through the glottis. Epi means above, so the epiglottis sits above the glottis. The actual hole is the glottis that air moves through. It acts as a sphincter to prevent air passage. You also have for speech is nothing but intermittent release of expired air with the opening and closing of the glottis. So air going through there, that is what allows for speech. The pitch, which is simply how high or low we talk, is determined by the length and the tension of the vocal cords. And the loudness, which is our volume, is due to the amount of air that we have coming through the glottis. Sound is shaped into language by muscles of the pharynx, the tongue, soft palate, and lips. All of those help with being able to speak and form words with our language. So here's a picture and what you're doing. You're looking down. If you notice the tongue, this is the back of the tongue that you're looking. So the structures here are sitting behind the tongue. So you can see the vestibular fold. You can also, on the sides here, you can see the vocal cords. And the vocal cords are white there. Those are the true vocal cords. And then you can see this is the picture when it's closed. Above it, here's the epiglottis. This is the picture when it's open. So when it's open there, you can see the actual hole, and that is known as the glottis. Next, we have the trachea. The trachea is also known as the windpipe. It's blocked by the epiglottis during swallowing. It is a wall composed of 3 layers of mucosa. Submucosa is also part of it. It's connective tissue with seromucous glands. Adventitia is another layer making it up. And it is made up of the rings that I said that you would see when you're always trying to identify the trachea. Look for those rings. So that adventitia rings are what you're looking at. And they're made of hyaline cartilage. And they open posteriorly, or in other words, towards the back. And they connect with the trachealis muscle. And that helps to alter the diameter as things, or the trachea is able to, or air is moving through the trachea. The carina is the last point, or the last trachea before it splits into the bronchi, and your cough reflex center is located there. And then from there, it branches into your 2 primary bronchi. It goes to the right and left towards your right and left lungs. So here's a picture showing that. You can see how this is the picture here. Look at it. So this is, if you zoom in and look at one of the rings, you can see that they open to the back. You can see the tissue layers making it up. The inner layer is the mucosa. The middle layer is the submucosa. And then you have the adventitia. That's a part of the hyaline cartilage here. You can see the inner layer, the mucosa, is lined with the cilia, which moves things along the tract. It also helps to trap things because you're continuously cleansing that air as it moves further towards or further down the tract. You can see the glands that are in the seromucosa glands, and they help produce the material like serous fluid and mucus fluid as well, goblet cells like mucus. And you have less mucus as you move down, but you do have some, and that's helping still to cleanse that air. This is just the histological picture, or in other words, how it would look under the microscope. And you can see all the different layers here. From the trachea, you have branching into the bronchi. You have your first area, which is the primary bronchi. Each main bronchus enters the opening into the lung. It's called the hilum. You have the right, it's wider, shorter, more vertical. The main bronchus will branch into the secondary, and you have 3 on the right, 2 on the left, for a total of 5 secondary. And then from the secondary, you branch into your tertiary, also known as your lobar bronchi. And then you have about 10 on each of those for a total of about 20. And then the segmental bronchi divide even further, and it gets even smaller and increase in branching, but the size of the bronchi will actually get smaller. From there, you have the bronchioles. The bronchioles are tiny, and they are 1 millimeter in diameter. The terminal bronchioles are the smallest. From the bronchi through the bronchioles, the structural changes will occur. The cartilage rings give way to plates or elastic fibers. Cartilage is absent from the bronchioles. So keep that in mind. So that's a structural change or something that's a little different. Also, the epithelial changes from pseudostratified to simple columnar. So you have less cilia, less goblet cells. In other words, as you move further down the track, you have less cilia, less goblet cells. And simple columnar goes to simple cuboidal. So those are the changes. So smooth muscle increase as diameter decrease. In other words, smooth muscle, remember, it's involuntary movement. And things are able to move along that track because of the function of smooth muscle. So this allows for the type of epithelial tissue is allowing for secretion and absorption. So you will increase in branching, but the size of the bronchioles actually get very small. So from the nares or the nose, when you're pulling it in up into the terminal bronchioles, you have ventilation only. And with ventilation, that is simply the movement of air. It's the movement of air, but you have no breathing, no exchange of gases whatsoever at this point, just movement of air. So you can locate those areas in the picture. You notice that the left lung would be 2 lobes, the right lung would be 3 lobes. So you can see, you can notice the superior lobe, but the main thing I want you to see is the trachea. You see how it branches into the primary branch into secondary, and then tertiary, and you get further and further branching. So you see the branching becomes very elaborate as you move deeper into the lungs. So the respiratory zone is what we're into now. Before you were in the conducting zone. So that's just movement of gas. Now we're leading up to the point where we actually have exchange of gas that will take place. And with that, you have the respiratory bronchioles that go into the alveolar ducts. The alveolar ducts go into the sacs, and the alveolar sacs consist of the individual alveoli. You have about 300 million alveoli that account for most of the lungs and the volume. Your book described it as saying is they can contain, remember the alveoli have the oxygen. So it said it's about enough oxygen molecules to fill a tennis court is the way that your book described it. So that's how much that are being packed into those lungs. And being packed in the individual alveoli helps to increase the surface area. As far as the respiratory membrane, you have an air-blood barrier. The alveolar wall is simple squamous type 1 cells, and those help with secretion. You have a superficial surface with a cobweb structure that's over the alveoli, and that's helping with gas exchange and helping with keeping the lungs from collapsing. But main thing, or the alveoli from collapsing, but the main thing you have is that keep the alveoli from collapsing would be the surfactant that's produced by the type 2 cells. So this allows to resist external force from taking place and pulling those alveoli in, and it keeps them open. So this is a picture here. You can see the entire structure here is the duct. You have the alveoli duct, and this entire structure is the sac, and inside of the sac would be each individual alveoli. And these are microscopic. So you see, if you zoom in on the picture here, that's what you're showing here. But alveoli, they are microscopic when you're into the respiratory zone. Going even further, you can see the capillary bed that's wrapped around it. This allows for picking up oxygen, dropping off carbon dioxide into the alveoli, and the elastic fibers, which allows for the alveoli to be able to change size, pretty much kind of contract, relax as gas moves through there. You can see the different types of cell. This is that barrier that's taking place here. You have oxygen going into the blood, carbon dioxide coming from the blood, which was picked up in the systemic circulation. You can see the types of cells, the type 2 cells that make it up. That's the ones. Type 2 is the one that produces surfactant. And then you have the alveolar wall that has the type 1 cells that helps with secretion. The alveoli, 3 features: the elastic fibers, the pores, and the macrophages. Macrophage is a white blood cell that helps to keep the alveolar area sterile. In other words, so that means that air, as you go further into the tract, is letting you know that the air exchange is sterile. So it's being cleansed as you higher up, but as you move further down the tract, it is sterile. It contains the open pores for exchange and those elastic fibers to help with being able to relax recoil. So this is the same picture showing you the fibers. You can see the capillary bed, the elastic fibers. You can see those holes in there. Those are the pores. Same thing. And you can see also the macrophages, which are those white blood cells that help to cleanse the air or keep the air sterile as you're further into the alveoli. Your lungs occupy all of the thoracic cavity except the mediastinum, and that's right there in the middle. And these are features that are found on the lungs. And so let's go to the next picture to actually see those. So you can see, and then also the cardiac notch is one of them. So you can see this is looking down at a transverse cut. So you can see the lungs sitting in the pleural cavity. You have parietal that's actually covering the lung, or visceral that's covering, parietal that's lining that pleural cavity. Then you have the space in between here, which you have a little of that serous fluid. You can see the opening here for blood vessels, the trachea, the bronchi, to actually go into the lungs, and that is called the hilum. You can also see the roots of the lung hilum. You see the heart sits here in front of it between the pleural cavity. Here is the sternum. So that's your orientation as far as what you're looking at. So here it is sitting in that thoracic cavity again. You notice the right lung has 3 lobes. Left lung has 2. Here is the apex. The top of it is the apex. The bottom of the lung is considered the base of the lung. Here's the cardiac notch. That's one way to know the left lung from the right also, because the left lung will have that notch to accommodate the heart, which sits mostly to the left. Your left lung is smaller. It has 2 lobes with the oblique fissure dividing it. The right lung has 3 lobes, and it has the oblique fissure and the horizontal fissure. You have about 10 segments in each lobe, so for a total of about 20 of the segmental when it divides from primary to secondary to tertiary. That's what it's talking about. Lobules are the smallest subdivisions. They're served by bronchioles and their branches. So mostly air spaces with stroma and elastic connective tissue. So this is another picture showing you those structures again with the lobes. Locate the lobes, right with 3, left with 2, and the fissures. Here's the oblique fissure, here's the horizontal, and here's the oblique, and those are on the right. Here's the branching, showing you the right lung with the different lobes and the branching going into it, and then the left lung, you can see it's branching with 4 segments and 5. And I know that's not quite 10, but most books you'll see it will say 10 and 10 on each. The blood supply, you have the pulmonary arteries, which carries deoxygenated blood, and then the pulmonary veins carrying oxygenated blood. And this is a review from chapter 19 because you know about the pulmonary circulation, hopefully. So those pulmonary arteries, that's when it's leaving the heart going towards the lungs. And that's why it's deoxygenated, because it's dropping off that carbon dioxide. And then the veins is what's pulling it, bringing it back into the left side of the heart after you've picked up the oxygen. The systemic circulation, you have the blood supply to the lungs. You have the bronchial arteries. And this is the supply that's supplying the lungs. So the lungs will be able to supply to the rest of the body. So the systemic circulation, you have the bronchial arteries. and this it's a branch off the aorta, and it supply all the lung tissue except the alveoli, which makes sense because the alveoli is already full of oxygen. Then you have the bronchial veins, which has a lot of branching, also known as anastomoses, with pulmonary veins. 2 layers of serosa, the parietal and visceral. Parietal lines the pleural cavity. Visceral covers the actual lungs. And then between it, you have the pleural fluid in the cavity, which is the small space. And this allows for lubrication and surface tension. So it allows for a little room, because remember, when you're breathing, your lungs are expanding and then going back down. So that space in between allows for a reduction in friction, because you don't want those lungs or the cavity, in other words, to any kind of sticking. Serosa or serous membrane is watery like. So this is showing that parietal lining the cavity located. Visceral is covering the actual structure. Then you have the pleural cavity here with the actual space that allows for free movement of those lungs. Now, as far as ventilation or movement of air, you have an inward force and an outward force that allows for that free movement to take place. So with that, you have atmospheric pressure, that's 760, that's the pressure on the outside. Then you have the pressure that's inside the alveoli, called the intra-alveolar pressure. So the pressure in the alveoli, and it fluctuates with breathing, but eventually it will always equal out to each other. So just think of that, the pressure on the atmosphere versus the pressure in the lungs. So with that, you also have intrapleural pressure. This is the pressure in the pleural cavity. That's the space between the visceral and the parietal. This is always negative. So so it's less than the atmospheric pressure. And then you have the negative intrapleural pressure, and it's caused by an opposing force. So that intrapleural pressure is always caused by an opposing force. You have 2 inward forces that promote lung collapse, and then 1 outward force that tends to enlarge the lungs and the elasticity of the walls. So the inward force, you have the elastic recoil and the surface tension of the alveolar fluid to decrease the alveolar size, and then you have the outward force. So these 2 opposing forces on each other, they will allow for or create that negative pressure that you need for gas exchange. So the negative pressure, you have the 760, 756 on the inside here, 760 here. So the intrapleural pressure, which creates that negative pressure, then you have atmospheric pressure. And because of these differences in pressure, it's going to create for inhaling, which is pulling in air, and then the exhale response, which is air exiting. And that's simply just diffusion. It's going to be a higher pressure in one area than another. So it's going to force gas exchange to take place. So it's moving from high concentration to an area of low concentration. Now, as far as pulmonary ventilation, which is your normal breathing, Boyle's law explains it as it's the relationship between the pressure and the volume of gas. So in other words, he states that at a constant temperature, pressure varies inversely. So in other words, as your pressure goes up, your volume will go down, or as pressure goes down, your volume will go up. So increase in volume equals a decrease in air pressure, and this leads to inspiration, which is pulling in air. So that's how Boyle's law explained the relationship for normal breathing in and out. Inspiration is an active process. Your volume increase because the diaphragm contracts, the sternum, rib cage, and external intercostal muscles move out, and pressure will decrease. So air rush out from the greater outside to your lesser amount on the inside, and that is what calls for exhaling. So in other words, what he stated about the rib cage, and it's just an inverse proportion. So as volume is up, pressure down. If volume is down, pressure is up. For expiration, it's quiet. Your inspiratory muscles will relax. Your rib cage and diaphragm move back to their resting position. Your thoracic cage, which is your chest area, it will go back down. So pressure increase and air will rush out. So this is forced expiration this is normal breathing. Forced expiration is you pushing out air beyond normal breathing. If I were to tell you to just push out all the air that you possibly can, and that uses your abdominal and intercostal muscles. But when we talk about the normal ventilation with Boyle's law, this is what he's explaining about everything that happens. So what I mentioned about the rib cage, think about you taking a deep breath in. With proper breathing mechanics, if you take a deep breath in, your chest should actually fill up with air and expand. So when you take a deep breath in, your chest will actually move out, your rib cage will move up, and your diaphragm moves down. That's breathing in. And so that's what this picture is showing, pretty much summing it up. When you exhale, your diaphragm will move up, your rib cage will move down, and your thoracic cage, which is your chest area, will go down because air has moved out and you're not filling up with air. So these are all natural responses that should take place when you inhale versus when you exhale. Physical factors that influence the movement of air can be airway resistance, friction or drag. It's an inverse proportion. So just think of it. If I have resistance in my pathway, it's going to decrease the movement of air. So increased resistance will decrease the flow of air. Alveolar surface tension, of course, can cause a problem with the movement of air, and that's dealing with your surfactant. And if you have you have less surfactant, that means your alveoli can collapse, and you have less oxygen that's being given away. As well as lung compliance, the ease or the expansion of your lungs. If you have increased compliance, increased expansion. If you have decreased compliance with the lungs not being able to expand, of course, that's decreased expansion. So all of these are factors that can influence the movement of air. Surfactant amount, the lungs being able to, whether they're open or collapsed, versus also having something blocking air, which is resistance. This is showing that that same thing. If you have increased resistance, you have decreased flow, but it's also showing that you have in your conducting zone, you have more resistance that can take place. So that's like from nose to the trachea. But as you move further along into the alveoli, bronchi, they're getting so small that you normally have less resistance within those areas. So normally when you have some type of resistance, it's higher up. These are different volumes that you will use to measure the type of or your breathing ability. Tidal volume is just measure the normal breathing. And these are normally tests done with what is called a spirometer. So if you had to do a normal breathing in, normal breathing out, that's measuring your tidal volume, and it's showing the capacity of your lungs. Inspiratory reserve volume, air that can be expired forcibly. So if I tell you to take a deep breath in and pull in all the air you possibly can, that would give you your inspiratory reserve. Expiratory reserve is if the air, I tell you a normal breath in, and then I said push all of the air out that you possibly can. And then your residual is the air that you cannot push out because it remains in the lungs, because it keeps the alveoli and the lungs from collapsing. So these are actually numbers that you would get from to measure the capacity of the lungs, and so you would use a spirometer from that. After you get those numbers, you can actually, the capacity, inspiratory capacity, vital capacity, that's simply doing the math, adding the tidal, the reserve, and expiratory reserve, and just putting in those numbers. Anatomical dead space is what you also have to consider. This is the air moving just from the nares to the terminal bronchioles, and this is what we said it was ventilation only. So when you're trying to calculate lung capacity, you have to actually consider that in the math. Alveolar ventilation rates, which is the movement through the alveoli, determines respiratory efficiency. In other words, how fast that air is moving, and your breathing rate. So your breath per minute times your tidal volume minus the dead space can kind of give you the rate as which air is moving in and out of the alveoli. And this is just a short chart showing that, comparing male to females. You know, the male capacity would be higher than a female because of the thoracic area being larger. And this is the capacity. Like I said, once you get those reserve volumes and tidal volumes, getting the capacity is simply plugging in more numbers and totaling up things to give you what you need there. Pulmonary tests that you can use to test your lung capacity or test breathing would be using a spirometer, and that's an instrument used to measure the volumes, and then simply doing minute ventilation, counting somebody's respiratory rates, the amount of gas moving in and out in 1 minute. Some people do it for 30 seconds and multiply it by 2. And that's 1. The chest moving up and down is 1. Up and down is 2. And that's how you would do proper breathing rates. As far as gas exchange with Dalton's law, his is the law of partial pressure. And it states that the pressure is a mixture of gas. Each gas has amount of pressure it is exerting in the atmosphere in its proportion, and is independent of other gases. So each of them have their own pressure that they are exerting. And what I mean by that is your atmospheric pressure, you can see, is nitrogen, oxygen, carbon dioxide, and water. Partial pressure is each of them is exerting their own amount of pressure to give you that 76. And then each of them is exerting their own amount of pressure in the alveoli to give you that 760. I said 76, I meant 760. And that is the amount of pressure each of them are exerting to help with creating what we call the pressure in the alveoli and the atmospheric pressure. As far as gas exchange, also, you have Henry's law. The amount of gas that will dissolve in a liquid is proportional to the partial pressure of the gas. So how much of it that will dissolve is based on with the previous chart I showed you how much pressure each of them is exerting in the entire mixture. So gases in the air have different solubilities compared to in water and in plasma pretty much. So that's what you're talking about. And so Henry law, how gas is explaining how gas move in and out of a solution. So exchange of oxygen and carbon dioxide across the respiratory membrane, their partial pressure gradient for oxygen in the lung is steep. Venous, the partial pressure of oxygen in the artery or vein is 40. And then of carbon dioxide is 45. In the alveoli is 104. And carbon dioxide is 40 and 104 is the oxygen. So carbon dioxide, because of their different partial pressures, this is what is going to force the carbon dioxide to move into the alveoli and the alveoli to move the oxygen out into the blood. They move and they will move at the same rate. So their difference in their partial pressure explains how they're able to move across that alveoli and bloodstream barrier from one place to another. Ventilation and perfusion coupling is important. Ventilation is the gas that's reaching the alveoli, its movement. Perfusion is the blood flow that's reaching. They must be coupled, or in other words, they must match in order for gas exchange to take place. So if you have a reduction in the movement of gas, it can affect blood flow, or blood flow can affect gas exchange. So they have to match each other in order for it to be an efficient process of gas exchange to take place across from alveoli to blood and blood to alveoli. So changes in oxygen in the alveoli can cause changes in the diameter of the arterioles. When your alveolar O2 is high, it causes your arterioles to dilate, which means it gets wider or bigger, open up more. When the alveolar O2 is low, your arterioles will constrict. So that means they get smaller. Here, with changes in carbon dioxide in the alveoli, will cause the changes in the diameters. But now remember the previous one with the oxygen, it caused a change in the arterioles. This one is going to cause a change in the bronchioles. So the alveolar, the CO2 is high, your bronchioles will dilate. When CO2 is low, your bronchioles will constrict. Dilation opens them up more, constriction shuts them down or closes them off. So you can see this is showing the alveoli, carbon dioxide going out, oxygen is going into the blood, carbon dioxide is coming in, and it's coming back into the left side. All of this is just pretty much saying due to the partial pressure in the different locations will cause the exchange to take place of carbon dioxide and oxygen going from one place to another. Then you have the partial pressure in the tissues that's going to force the oxygen into them and force the carbon dioxide out. The membrane for the respiratory membrane, it's very thin. And of course, think of something having to go through a thick wall versus a thin wall. So it is thin, 0.5 to 1 micrometer, and it's about 90 square meters. So that's 40 times that of your skin as far as how large the surface area is for the respiratory membrane. Capillary gas exchange in the body tissues. This allows for the capillary, remember that's the location where the gas exchange is taking place. So with that being said, the partial pressures and diffusion gradients are reversed compared to external respiration. So the O2 in tissue is lower than in the systemic area. So that's going to force blood to go from high concentration, which is from the systemic blood, to low concentration, which is into the tissues. So the partial pressure is different there to force it from the blood into the tissues and then force carbon dioxide from the tissues back into the blood so it can head back towards the right atrium. Next, you have transport, which is oxygen, carbon dioxide being carried in the blood. And you have molecular O2. You have some of your oxygen that's going to dissolve, but most of your oxygen, you notice, will be carried on the iron molecule of your hemoglobin molecule. And you have 4 oxygen molecules per hemoglobin protein that you have. So some of your oxygen dissolve, if you notice, but most of that oxygen is being carried on hemoglobin. So with that transport, you have oxyhemoglobin, is hemoglobin oxygen combination, while reduced hemoglobin or deoxyhemoglobin is hemoglobin that has released oxygen. When all 4 of the hemoglobin molecules are bound to it, that is meaning that it is considered to be fully saturated. Okay, so this is a picture showing that, I don't expect you to know this chart, but it's showing you the saturation when you have all 4 compared to when you have less hemoglobin molecules, less iron, which is less oxygen being carried there. That's a difference in those partial pressures of oxygen based on the saturation. So the amount of oxygen carried by hemoglobin depends on the oxygen available. So at sea level, there are lots of oxygen. At a partial pressure of oxygen in the lungs can be fully saturated with 100% millimeters of hemoglobin, of mercury. So the hemoglobin is 98% saturated. At a high altitude, there is less oxygen. At a partial pressure of oxygen in the lungs of only 80 millimeters of mercury, hemoglobin is only 95% saturated. So the amount of the saturation is based on what is actually available. Here you can see several factors can influence binding of oxygen to the hemoglobin. Arterial blood is 98% saturated, and venous is 75% saturated. Temperature can affect it. The partial pressure of carbon dioxide can affect it. BPG, that's not something I expect you to know, but it's an organic chemical, and it causes a decrease. All of these can cause a decrease of oxygen being able to bind to the hemoglobin, and this causes O2 to enhance unloading. Bohr's effect state that the less pH, the lower the pH, which means you have a higher number of hydrogen ions, will weaken hemoglobin oxygen binding also. So this leads to unloading is accelerated also. So in other words, when the pH is low, or in other words, you have an increased amount of oxygen, it will increase the unloading of the hydrogen or the oxygen molecules. Nitric oxide can also, which is secreted by the lungs, can also cause a decrease in blood pressure. And this will enhance loading and unloading of oxygen. So all of these are factors that can increase your oxygen amount, and it will be a response in the body that take place. If I have increased carbon dioxide, that's going to make my oxygen loading increase to try to get some of that carbon dioxide out. If I have increased hydrogen ions, that's going to increase my oxygen unloading to get some of those hydrogen ions out. Because remember, the pH of blood is about 7.4. And if you have increased hydrogen ions, that's decreasing the pH, making it more acidic. And that's not something you want. So your body will respond. These are compensatory mechanisms that will respond to get your oxygen levels up based on whatever is going on in the body. Carbon dioxide is also transported in the blood. Some of it dissolves in plasma. You have a small amount that is bound to hemoglobin, but it's actually bound to a different area than the oxygen. So it's not bound to the same area. And then you have 70% that's transported as bicarbonate, and that acts as a buffer. Bicarbonate ions acts as a buffer, and they help to keep things balanced as far as in the body, should I say. So they act as a buffering system with that bicarbonate and keep your pH levels correct. This here is something, just a picture that I need you to be familiar with. And this helps with showing how things load and unload the oxygen compared to the carbon dioxide. And it's showing, you can see some of it dissolves in the plasma. Some of the carbon dioxide binds with water to give you your bicarbonate ions. And then you have some of it that goes into the red blood cell. It binds with water to create carbonic anhydrase. That is an enzyme that will speed up this reaction to bind the hydrogen to the carbon dioxide to give you more bicarbs, to give you chloride, and to give you hydrogen ions. Some of them hydrogen ions will bound, but as you increase the oxygen here, some of the carbon dioxide bind to the hemoglobin. But it's showing that as you get that increase of the carbon dioxide that rushing into the blood, it's going to increase the oxygen unloading and push oxygen out into the tissues. So if I get an increase of carbon dioxide coming in, it's going to increase the unloading of oxygen going out. And then the same will be vice versa. So that's why I put equation here, just for you to kind of write the equation that's going on here to cause that reaction to take place. And then it will be the opposite to push carbon dioxide into the alveoli and out of the blood, and that'll push oxygen into the blood to head to your tissues. That acts as a part of a buffering system. You have slow, shallow breaths that raise carbon dioxide levels in the blood and decrease pH. And this will lead to rapid, deep breathing and flush carbon dioxide out of the blood and increase pH. O2 concentration determines your hemoglobin's affinity for CO2. So where you have CO2, you won't have O2. And if you have O2, you won't have CO2. And that's what Howden effect is saying. So what he is saying here, decreased oxygen will equal decreased carbon dioxide, and vice versa, pretty much. That's what he's saying. So the effect of, if you have increased oxygen in the area, it's going to increase oxygen is going to push out carbon dioxide. Increased carbon dioxide will push out oxygen. Control of our respiration rate or breathing is in our brain center. It involves neurons in the reticular formation of the medulla and the pons. And those are two structures of the brain stem. The dorsal respiratory group, or the DRG, sends out a signal every 2 seconds to cause you to breathe in, and it stops for 3 seconds to cause for breathing out. The respiratory rate, and that sets your respiratory rate at about 12 to 15 breaths per minute. And some books will say normal breathing, about 12 to 20 breaths per minute is normal breathing. And that's called eupnea. Eupnea is another word for normal breathing. And you can see those centers here. The DRG here in the brain stem. And here's the pons, and you can see the pontine respiratory center also. And then you can see the VRG, and I believe I made a note of that. It's less understood and it's more active in strenuous exercise. I'm sorry, I didn't mean to go back. But you can see the innervation from that center also that's going to the diaphragm and to your intercostal muscles that assist in breathing. Your pneumotactic center is actually, it inhibits respiratory inspiratory impulses to prevent apneustic breathing and fine tuning. So in other words, it helps to keep your breathing smooth and keep a smooth pattern. So this center is inhibited, or is actually closed, blocked off, to prevent that spastic breathing and keep your breathing smooth. The apneustic center produce abnormal. When it's not inhibited, it will cause you to breathe abnormally. Deep breathing, prolonged gas, and it's located in the pons center also. Other factors to affect breathing: higher brain centers take voluntary control, like emotions, pain, send a signal to cause your breathing to increase or decrease. Stretch receptors in the lungs can send a signal to control breathing. Irritant receptors like accumulated mucus, inhaled debris, they can stimulate your cough center, cause constriction. Your central chemoreceptors, peripheral receptors can also cause it. That's like your pH levels, which affect loading and unloading. Pain and emotional response, these all can affect your breathing. Your main stimulant to affect your breathing would be carbon dioxide. When you have increased carbon dioxide levels, it will decrease your oxygen, and it will stimulate your bone marrow to release blood cells, and your blood cells will give you more oxygen. So when you have increased oxygen, it's going to stimulate more, increased carbon dioxide is going to stimulate oxygen to be made to get that carbon dioxide out of there. So that's your most powerful stimulant in the respiratory center. Make sure that you look over these and be prepared for a matching term, a matching section on your test. And also there is a movie about the respiratory center, or the respiratory system, that I need you to watch, and it will be available in Canvas. It goes through, it doesn't really give brand new information, but it helps with the notes. But there are a few questions pertaining to that DVD also. Any questions, make sure you email me.